We're going to continue from where we stopped. Acute pancreatitis. Scenario: a male with epigastric pain. You have 6 minutes to take history from your patient. As you already know. Hello, I'm Dr. Omar, one of the surgical doctor working here. May I confirm your name and age, please? So you introduce yourself and you asked for your patient name and age. You will have marks for this one. Hi doctor, yes, my name is John Smith and I'm 52 years old. Nice to meet you, Mr. Smith. I will be your doctor today. Is that okay? Yes, doctor, that's fine. How can I help you today? So you took permission. I have abdominal pain and I'm not sure what's causing it. Analyze the pain using Socrates, as we said. Whenever your patient complaining of pain, analyze the main complaint. I'm sorry to hear that. Be sympathetic with your patient. I'm sorry to hear that. Could you please point to the site of the pain? The pain is mainly in the middle of my abdomen. I see. You are communicating to your patient. When did you first notice this pain? 1 week ago. Mr. Smith, did it start suddenly or gradually? It started gradually, but it's been getting worse over the past few days. Has it been constant or does it come and go? Come and goes, but lately it's been more constant. Is there a specific time of the day when the pain worsens? Yes, it usually gets worse after I eat. Mr. Smith, can you describe the pain for me? Is it colicky, cramping, or stabbing? It's more like cramping pain and it's pretty severe. Does it move anywhere? Perhaps to your back? Sometimes it radiates to my back. Does leaning forward alleviate your pain or make it worse? Leaning forward makes it better. On a scale of 1 to 10, with 10 being the worst pain imaginable, how would you rate it? As we said, memorize this sentence because you're going to use it for every single pain on severity. Differential diagnosis. Your first differential is acute pancreatitis. Does it decrease by leaning forward? Yes, and he already answered this question. Mr. Smith, have you noticed any difficulty flushing a stool? No, it's normal. Have you experienced fever or illness recently? No, doctor. Myocardial infarction. Does your pain go to your arm? No. Do you have chest pain along with your tummy pain? No. Any shortness of breath? I don't have shortness of breath, doctor. Mr. Smith, look, we're mentioning the patient name as usual. Make sure you mention your patient name. Do you feel your heart beats? No. Third differential, GORD. So you had your first differential acute pancreatitis, second is MI, and the third is GORD or GERD. Did you ever experience acid reflux or heart pain? Occasionally, doctor, but not often. Fourth differential, acute cholecystitis. Does the pain move to the right shoulder? No, just to my back. Does the pain increase with eating? Yes, especially with fatty meals. Any fever? I told you before, doctor, no. When your patient gets anxious or upset, try to calm him down. Any change in the color of your urine or stool? No. Mr. Smith, have you noticed any yellowish discoloration of your eyes? No. Your fifth differential is IBD, inflammatory bowel disease. Mr. Smith, did you notice any redness in your eyes? No. Have you had any mouth ulcers? No, doctor. Any joint pain? No joint pain. Any skin problem? No. That's good to hear. So when your patients tell you he has no symptoms, that's a pleasant thing to hear, right? So tell him that's good to hear. Past medical and surgical history. Do you have any other medical condition? I have high blood pressure, but other than that, I'm pretty healthy. Mr. Smith, have you had surgeries in the past? I've never had surgery before, doctor. Family history. Is there anyone in your family experiencing similar symptoms before? No. Drug history. Are you currently taking any medications? I take medication for my high blood pressure. Do you have any allergies? No, doctor. Social history. Do you mind if I ask you personal question as we said before in the social history? Ask your patient, do you mind if I ask you personal questions? No, doctor. Carry on. What is your occupation and who lives with you? I work as an accountant and I live with my wife and 2 kids. Do you have any difficulty with the stairs? I don't have any trouble with the stairs. Do you smoke? I don't smoke. Mr. Smith, do you drink alcohol? Yes, doctor, I do. How many units per week? Around 15 units per week. And we said every unit equals 10 ml or 8 grams. And then idea, concern, and expectation, ICE. This will give you marks for communications skill. In the every single history station, you have 4 marks for communication skills. You ask about ICE as we already showed you before, idea, concern, and expectation. Before we proceed further, what do you think might have caused these symptoms? I'm not sure what caused any. What concerns you the most about your condition? I'm worried it could be something serious. What are you hoping we can do for you? And then systemic review, as you know, you ask from head to toe. Most important question, headache, chest pain, shortness of breath, belly pain, urinary symptoms, and joint pains.
At the end, always thank your patient. Thank you, Mr. Smith. I will discuss this with our senior or with my consultant, and I will get back to you. For now, we may need to do specific examination and request a specific investigation, and we will take it from there. I will update you shortly.
Then you will have 3 minutes to discuss with your examiner. Discussion. Present your patient. Always memorize this or practice this. You have to know how to present your patient. And this is particularly very important because it is the first impression between you and your examiner. Present your patient. I present Mr. John Smith, or I took a clinical history from Mr. John Smith, a 52-year-old accountant. If you forgot the name, just say I took a clinical history from this gentleman. Presents with a week-long history of epigastric pain, which has progressively worsened over the past few days. He describes the pain as cramping and notes radiation to the back. The discomfort intensifies after meals, especially with fatty foods, and alleviated by leaning forward. Mr. Smith has a past medical history of hypertension but denies any previous surgeries. He drinks more than 15 units of alcohol per week. What are your differential diagnoses? Acute pancreatitis, gastroesophageal reflux disease, GORD, myocardial infarction, acute cholecystitis, peptic ulcer. What is your main differential diagnosis? Acute pancreatitis. How will you investigate your patient? I will do full clinical examination. As we said before, always mention that you're going to do clinical examination after your history station. Then I will request blood tests including serum amylase and lipase level for pancreatic function, complete blood counts, and liver function test for sign of infection or inflammation. Imaging, abdominal ultrasound for pancreas and gallbladder assessment, CT scan if ultrasound is inconclusive or complications are suspected. ECG plus cardiac enzyme. Cardiac enzyme we mean troponin to rule out myocardial infarction. Upper endoscopy OGD to assess the upper gastrointestinal tract for sign of GORD or peptic ulcer disease. Alcohol assessment, evaluation of alcohol consumption for its potential role in pancreatitis development. How will you treat your patient? According to the care of critical ill surgical patient, then I will start by doing ABCD approach, and you're gonna mention what is A, what is B, what is C, what is D, what is E. A, airway, B, breathing, C, circulation, D, disability, E, exposure. Admission to HDU/ICU, provide analgesia for pain relief, ensure aggressive fluid rehydration, administer supplement oxygen as needed, perform close monitoring for vital signs. Frequent monitoring, monitor liver function tests, renal function tests, clotting profile, serum calcium, and blood glucose. And if you remember, these all are part of the criteria for diagnosis of acute pancreatitis, Glasgow criteria, and Ransom criteria. A specific intervention, consider nasogastric drainage initially, use antibiotic if indicated, administer octreotide to decrease pancreatic secretion. An octreotide is somatostatin analog. Prescribe BBI to prevent stress ulcer. Further evaluation and treatment, order the CT scan if needed. Plan ERCP within 72 hours if severe or sign of cholangitis are present. Supportive measures, provide supportive therapy for organ failure. Consider nasovaginal tube for nutritional support if required.
And why do you think we do nasovaginal tube instead of nasogastric? I will give you a minute to think. Pause the video and think. Okay, nasovaginal to avoid nasogastric. And why we're avoiding nasogastric? To prevent activation of the pancreatic enzyme. And how is that? When you do nasovaginal, that means that you will go past the ampulla of Vater. So there will not be connection. You will pass the duodenum to the jejunum. The pancreas will not be activated. If the pancreas is activated, then acute pancreatitis may get worse.
Thank you, doctor. You can proceed to the next station. As you know, at the end, you will find the most important questions in the differential diagnosis and what's your differential diagnosis. So the differential diagnosis is on your left, and here how to ask about it. Next, inflammatory bowel disease, IBD. Scenario: a female was referred by high GB with suspected case of inflammatory bowel disease. 6 minutes to take history from your patient. Introduce yourself and take permission. I just want to mention here, even if the scenario said a female was referred by high GB with a suspected, for example, acute cholecystitis, let's say, then you're going to discover from the history that the patient has no acute cholecystitis. It doesn't matter how they write the scenario. What matters is what your patient going to say for you and your clinical sense. 6 minutes to take history from your patient. Introduce yourself and take permission. You will have mark for this one. Hello, I'm Fiona, one of the surgical doctors working here. May I confirm your name and age, please? As we said, don't say I'm one of the exam candidates. Say I'm one of the surgical doctors working here. Nice to meet you. My name is Lucy and I'm 35 years old. Nice to meet you, Miss Lucy. I will be your doctor today. Can I ask you a few questions? That's fine, doctor. How can I help you today? I've been experiencing abdominal pain. I'm so sorry to hear that. Change your tone. Analyze your symptom using Socrates. Could you describe where you feel the pain? It's mainly in the lower part of my abdomen. When did you first notice this pain? It started gradually a few months ago and it comes and goes, but it's been getting worse lately. Miss Lucy, we're mentioning our patient name. Miss Lucy, how long does this episode of pain last? They can last for several hours. Miss Lucy, how would you describe the pain? Is it sharp, dull, or cramping? Whenever you ask a vague question, give your patient choices. It's more like a cramping sensation. Do you notice any specific times when the pain gets worse? The pain tends to flare up after meals. Are there any activities or foods that make the pain worse or better? Eating certain foods, especially spicy or fatty ones, seems to trigger it. Have you noticed any other symptoms along with the pain? Yes, I've been having diarrhea and sometimes notice blood in my stool. How would you rate the pain on a scale from 1 to 10? It's usually around 6. Or you can ask differently. From 0 to 10, with 10 being the worst pain imaginable, how would you rate your pain? Differential diagnosis, IBD, inflammatory bowel disease. Miss Lucy, did you notice redness in your eyes? Yes. Any joint pain? Yes. Any skin change? Yes. So now probably this is IBD. Miss Lucy, have you noticed any slime or discharge? Yes. Any pain in your tummy, especially with bowel opening? She said no. Your patient sometimes may contradict himself. Don't let this fool you. Put everything in content. Your patient sometimes may contradict himself. Be aware. Don't let just one answer fool you and change your diagnosis. Do you have any disturbance regarding bowel habits? What do you mean, doctor? I mean, is there any constipation or diarrhea? Yes, I have diarrhea with blood. IBS, irritable bowel syndrome. Is the tummy pain relieved by passing stool? No. Miss Lucy, did it increase when you are stressed? No. Do you have bloating? No. Third, differential malignancy. How has your appetite been? It's the same, doctor. Have you noticed any unintentional weight loss or general tiredness? No. Fourth, differential gastroenteritis. Have you been abroad recently? What do you mean abroad, doctor? I mean outside the country. No. Do you have the air to pass stool despite passing a small amount? No. Fifth, differential biliary colic. Miss Lucy, does the pain move to the right shoulder? No. Have you noticed any yellowish discoloration of your eyes? No. Past medical and surgical history. Have you experienced similar symptoms before? No, this is the first time. Do you have any other medical condition or surgeries in the past? No, I'm generally healthy. Family history. Is there anyone in your family with similar symptoms? Not that I'm aware of. Social history. And as we said, always in the social history, take another permission because you're going to ask personal questions. Do you mind personal questions? That's fine. Miss Lucy, do you smoke? Yes, I smoke 2 packs a day. Do you drink alcohol? No. Idea, concern, and expectation, as we showed before, and then systemic review. If you have time for this, that's fine. This will give you a mark for communication skills. But if you don't have time, you will escape it. Okay? Always practice to finish with eyes and systemic review. Then you will have 3 minutes to discuss with your examiner. Discussion. Present your patient. I took clinical history from Miss Lucy, who presented with symptoms suggestive of inflammatory bowel disease. As we said, you can mention medical term while you are presenting your patient because you are speaking to a doctor or a surgeon. Her symptoms include abdominal pain, red eyes, diarrhea, and occasional blood in the stool. What are your differential diagnoses? Inflammatory bowel disease, gastroenteritis, and diverticulitis. How will you investigate this patient? I will do full clinical examination. As we said, always mention the clinical examination first. Then I will request blood tests including full blood count, CRP and ESR, fecal calprotectin, and occult blood test. Imaging studies including colonoscopy, CT, or MRI. How will you treat your patient? I will discuss her in the MDT meeting. As we said, always mention the MDT in your treatment. But the general approach includes lifestyle modification, medication to reduce inflammatory and manage symptoms like prednisolone and infliximab, dietary modification, low residue diet, referral to gastroenterologist for further evaluation and management. A last resort for the treatment is surgery. Failure of medical treatment or complications, and what surgery? Partial or total colectomy. Here you have the table at the end which has the differential and how to ask about each one. Next station, shortness of breath / anxiety. Scenario, anxious lady who is having surgery soon. Introduce yourself and take permission. Here you have 6 minutes, as you know, to discuss with your patient. Introduce yourself and take permission. Good afternoon, I'm Justin. May I confirm your name and age, please? This will give you mark. Hi, doctor. My name is Rumaisa and I'm 43-year-old. Nice to meet you, Miss Rumaisa. I will be your doctor today. Is that okay with you? How are you feeling today? I've been feeling quite anxious lately. I've been experiencing shortness of breath, especially in the past 10 days, and it's been really bothering me. I'm so sorry to hear that, Miss Rumaisa. So you change your tone. Anxiety can be quite distressing, especially when it affects your breathing. Would you like me to give you some oxygen to help you feel more comfortable? Your patient could say yes or no. If she said yes, you're going to give her the oxygen. If she said no, that's fine. Yes, please. That would be helpful. Then you're going to take the oxygen and give it to her. The other station that we give oxygen on was pulmonary embolism. After you give the oxygen, then ask your patient politely, can we continue now? She will say yes, please. Did your shortness of breath start suddenly or gradually? Gradually. Ms. Rumaisa, had this condition been improving or worsening over time? It's gotten worse recently, especially since I found out about my scheduled cholecystectomy. And here the trick. Here you will know your patient is just anxious about her procedure. Does it happen all the time or does it come and go? Comes and goes, but it's been happening more frequently lately. Why? Because her surgery is closer and closer. The episodes usually last for a few minutes each time. Mr. Maisa, have you noticed anything that triggers or worsens the episodes? We keep mentioning the patient name. It seems to get worse when I'm feeling particularly anxious or stressed. That's another clue. Are there any factors that seem to make it better? Taking deep breaths and trying to calm down usually helps a bit. Differential diagnosis. Pulmonary embolism, your first differential. Mr. Maisa, do you have any chest pain? No. Did you notice any cough, swelling, or pain? No. Mr. Maisa, did you vomit? No. As you can see here, we didn't ask about all the differential of pulmonary embolism. For example, we didn't ask about previous surgery or recent surgery because we know she has no recent surgery, and also you don't need to ask about every single question to differentiate. Malignancy. Did you notice any unintentional weight loss? No. Mr. Maisa, how about your appetite? It's fine, doctor. Pneumonia, your third differential. Have you experienced any fever? No, I haven't had any fever. Any cough or mucus? No cough, and I haven't noticed any mucus either. Heart problems. Do you feel your heart beats? I don't notice my heart beats unless I'm feeling anxious. Have you experienced any difficulty breathing when lying flat? I haven't had trouble breathing when lying flat either. Past medical and surgical history. Mr. Maisa, did you experience similar symptoms before? Yes, when I'm overwhelmed. Were you diagnosed with any medical condition? No. Mr. Maisa, have you had a history of surgery before? No. Family history. Is there anyone in your family who experienced the similar symptoms before? No. Drug history. Mr. Maisa, don't forget to mention the patient name couple of times. Do you take any regular medication? No. Do you have allergies? No. Social history. What do you do for a living? I'm an accountant. Who lives with you? My family. Mr. Maisa, did you have any difficulty with the stairs? Sometimes, doctor. And then, as we said, idea, concern, and expectation, eyes. If you have time, you need to ask for it. It will give you mark for communication and also systemic review as showed before. Then you will have 3 minutes to discuss with your examiner. Discussion. Summarize your case or present your case. I took a clinical history from Ms. Rumaisa, a 45-year-old woman. If you forgot her name or her age, you can just say, I took a clinical history from this lady. She has been experiencing shortness of breath for 10 days, with episodes lasting a few minutes, worsening in frequency after being scheduled for cholecystectomy. The shortness of breath does not appear to be related to cardiac or pleuritic chest pain. My top differential diagnosis is anxiety relating to her impending operation. I will also consider interstitial lung fibrosis, bronchial asthma, pneumonia, pulmonary embolism, and bronchogenic carcinoma. What's your management? First, I will perform full clinical examination. As we said, always mention clinical examination in the history before your investigation, including chest and cardiovascular examination. Then I will contact the GB to obtain all the notes regarding the patient investigations. I will order to repeat investigations including ABG, CBC, ECG, and chest X-ray and pulmonary function tests. You want to make sure that's just an anxiety and no organic cause. I will ensure she has a recent angiogram and discuss this with the cardiologist. Reassurance is crucial, so I will involve her close relative or friends to ensure an adequate support network. Should the surgery proceed, as there is no evidence of cardiac or respiratory illness, the operation can proceed. Your second differential diagnosis is interstitial lung fibrosis. So answer this question. Define FEV1. Volume of air exhaled at the end of the first second of forced expiration. Define FVC. The amount of air that can be forcibly exhaled from the lung after taking the deepest breath possible. Define FEV1 divided by FVC ratio. The FVC ratio, also called modified Tiffany-Pinel index, is calculated ratio used in the diagnosis of obstructive and restrictive lung disease. It represents the portion of the person's vital capacity that they are able to expire in the first second of forced expiration compared to the full force vital capacity. And you can see the picture on the app on the school that explain FEV1 and FVVC. Please have a look for this picture on a school. Next, headache. Scenario. Basketball player started to feel sudden headache, feeling like sharp pain at the back of the head and started to get worse suddenly. 6 minutes to take history from your patient. Introduce yourself and take permission as usual. This will give you marks. Hello, I'm Aliyah. I'm one of the surgical doctors working here. May I confirm your name and age, please? Don't say I'm one of the exam candidates, as we said. My name is Anna. I'm 40 years old. Nice to meet you, Miss Anna. I will be your doctor today, if that's okay with you. Here you are taking a consent. Miss Anna, how can I help you? I have severe pain at the back of my head. I'm so sorry to hear that. Don't worry, you will be in safe hands. Be sympathetic and reassure your patient. I'm really sorry to hear that. Don't worry, you will be in safe hands. Do you want me to prescribe any painkillers? Yes, please. Okay, I will do that now and you can have them after the discussion. Do you want me to dim the lights? Yes, please. I will do that now. Analyze the main complaint using Socrates. Site, onset, character, duration, timing, severity, aggravating and relieving factor, and associated factor. Where exactly do you feel the pain? The pain is mainly located at the back of my head. Could you please point to the site near the base of my skull? Is it on one side or over the head? It's mainly on one side. Miss Anna, when did it start? It started approximately 2 hours ago. Did it start suddenly or gradually? It started suddenly while I was at work. Could you please describe that pain for me? Is it thunderclap headache, colicky, dull, crushing or cramping or stabbing? The pain is sharp and stabbing. Does it move anywhere else? Sometimes it radiates to my temples and down my neck. Is the pain constant or does it come and go? The pain comes in waves. It's not constant, doctor. How long does it typically last? Each wave lasts about 10 to 15 minutes. I'm really sorry. Be more sympathetic. Does anything make it worse or better? Bright lights and loud noises make it worse. Resting in a quiet dark room helps a bit. Could you score the pain for me, please, on a scale of 1 to 10? Being the worst pain you could imagine. I would rate it around 7 or 8, so pretty severe. Miss Anna, so we're mentioning the patient name. How does your pain affect your life in general? The pain is making it difficult to concentrate at work and I feel nauseous. I'm really sorry to hear that. Don't worry, we will take care of you. Differential diagnosis. First, subarachnoid hemorrhage. Did you vomit? Yes. Miss Anna, what did the vomit look like? The vomit was very intense. Why are you asking about the vomiting? Because it's one of the signs of increasing intracranial pressure, as you know. That must be hard, Miss Anna. Yes, doctor, it's been hard. Be sympathetic. Miss Anna, have you been diagnosed with any kidney disease? Yes, I've been diagnosed with kidney disease. Second differential. So from the history now, you know your diagnosis is subarachnoid hemorrhage probably. Trauma. Have you injured your head recently? No, I haven't had any recent head injuries. Third differential meningitis. Do you have stiffness in your neck? Yes, my neck feels stiff and sore. Are you sensitive to light? Yes, I'm sensitive to light. Do you have a fever? No, I don't have a fever. Miss Anna, have you noticed any skin rash? No, I haven't noticed any skin rash. Fourth differential malignancy. Have you experienced any weight loss? No. Any change in appetite? No. Have you ever had seizure or loss of consciousness? No, I haven't had any seizure or loss of consciousness. Miss Anna, do you have weakness in your legs or hands? No. Do you have numbness in your legs or hands? No, I don't have numbness in my legs and hands. So sensory and motor are intact. Are you experiencing any disturbance in your vision? No. So probably that's not a malignancy. Past medical and surgical history. Miss Anna, did you experience similar symptoms before? No. Were you diagnosed by any medical condition? Yes, polycystic kidney disease. And that will give you the answer. Any surgeries? No. Family history. Does anyone in your family have a similar condition? No one in my family has a similar condition. Miss Anna, is there a history of kidney disease in your family? Yes. And she already has polycystic kidney disease. Drug history. Miss Anna, do you take regular medication? No. Do you have allergies? No. Social history. I would like to ask you a personal question. Is that okay with you? As we said in the social history, we take another permission. Okay, go ahead. Miss Anna, what do you do for living? I'm a teacher. Do you have any difficulties with using stairs? Yes. Do you smoke? No. Miss Anna, do you drink alcohol? No. How badly is this affecting your day-to-day life? It's been quite challenging. The pain makes it very difficult to concentrate, and I had to cut down in my activities. I'm really sorry to hear that. We will do our best to help you. Idea, concern and expectation, as we showed before. If you have time, ask for this. This will give you mark for the communication. Systemic review, if you have time, start from head to toe. Most important questions: headache, shortness of breath, chest pain, belly pain, urinary symptoms, joint pain and muscle pain. 3 minutes to discuss with your examiner. Discussion: present your patient or present your case. Always practice this. So many students don't practice this, which is wrong. Practice this always. I took a clinical history from Miss Anna, 45-year-old woman, known case of polycystic kidney disease. This is very important, who presented with severe headache, which is sudden in nature and associated with projectile vomiting. So my main differential is subarachnoid hemorrhage. What are your differentials? Meningitis, increased intracranial pressure due to brain tumor, migraine headache, glandular arteritis. What are the signs of increased intracranial pressure? Morning headache, projectile vomiting, local neurological deficit, papilledema, and Cushing triad. How will you manage this patient? I will do full clinical examination. As we said, always mention that you will do full clinical examination. Plus, then I will request blood investigation, including full blood count, electrolyte like calcium and magnesium, and ABG. Imaging, CT brain. CCF tabbing. Treatment, I will discuss my treatment in the MDT meeting then. I will first treat the increased intracranial pressure. What is the treatment of increased intracranial pressure? We have non-operative option and operative option. Non-operative option, hyperventilation, can be used as a temporary measure. Elevation of the head of the bed to 30 degrees. Reducing cerebral edema by cooling the brain using barbiturate and osmotic diuretics like mannitol. If intractable, raised intracranial pressure, a thiopentone infusion to decrease cerebral metabolic rate to a basal level. So 4 measurements to decrease the intracranial pressure non-operatively. 1. Hyperventilation. 2nd, elevation of the head of the bed to 30 degrees. 3rd, reducing cerebral edema by cooling the brain using barbiturate and osmotic diuretic like mannitol. 4th, if intractable, raised intracranial pressure, thiopentone infusion to decrease cerebral metabolic rate to a basal level. Surgical option, decompression by removing hematoma, decompression craniotomy, and drainage by catheter. After treating increased intracranial pressure, then refer this patient to a neurosurgical unit. Fluid, 3 liters of IV fluid per 24 hours. Oral nimodipine, 60 mg every 4 hours. And mannitol. Why we give nimodipine? Because it prevents vasospasm of the cranial arteries. Barbiturate to prevent seizure. Surgery, we have 2 choices: PAR hole, PURR holes, or craniotomy. What is nimodipine? Nimodipine is a calcium channel blocker which prevents vasospasm. What is coil? Coil is endovascular treatment of aneurysm and bleeding. It reduces blood circulation to aneurysm by using microsurgical platinum wires inserted into the aneurysm until determined blood flow not occurring in this space. Here you can see a picture for the coiling. This will give you an idea. Thank you, doctor. You can proceed to the next station. And at the end, the differential diagnosis and how to ask about each one. Next one, dysphagia. Scenario, an old man with difficulty swallowing. Hello, I'm Dr. Ayan, one of the surgical doctors. May I confirm your name and age, please? Here, you're introducing yourself. Hi, doctor, I'm Joe, 65-year-old. Nice to meet you, Mr. Joe. Today I will be your doctor. Are you okay with this? That's fine, doctor. How can I help you today? I have difficulty swallowing, doctor. I'm really sorry to hear that. Analyze the main complaint using Socrates. When did you first notice this? 6 months ago. By neglected it. Mr. Joe, we mentioning the patient name. This starts suddenly or gradually? It was gradual, doctor. Is there anything that makes this difficulty stop? No, it's constant. Is there anything that makes difficulty increase? Yes, solid food, doctor. Do you experience this difficulty in swallowing solid or liquid food or both? That's a very important question. It was for solid food at first, but now even liquid are difficult to swallow. Differential diagnosis. CA esophagus. How has your health been recently, Mr. Joe? I feel so tired, doctor. Have you noticed any unintentional weight loss? Yes. How many kilos? I'm not sure, but my clothes are getting scary loose in the last 2 months. Mr. Joe, have you vomited at all? Yes. Was there any blood? There were streaks of blood. Now you know it's a cancer. How has your appetite been? Badly, doctor. I barely eat. Second differential. Goiter. Have you noticed any neck swelling or feeling a lump in your neck? No. Third differential. Pharyngeal pouch. Did you notice the regurgitation of food while lying down? No. Mr. Joe, have you noticed having a bad smelling breath recently? No. Do you ever notice gurgling or wet voice after swallowing? No. GORD, your fourth differential. Did you ever taste acid at the back of your mouth? I used to have that when I was young. Any heartburn? Yes, sometimes. That must be difficult, Joe. Yeah, I have. Yeah, I'm just trying to cope with all of this. I understand. So you are communicating back to your patient. Fifth differential, echalasia. Have you noted that the difficulty is more to fluid than solids? I already answered that question. No, it's for solid more than liquids. Yeah, I know. I just want to confirm. So when your patient gets angry, try to calm him down. Sixth differential. The sixth differential is esophagitis. Mr. Joe, have you had a fever? No. Have you noticed pain during swallowing? No, it's just difficult to swallow, not painful. 7. Autoimmune disease. Myasthenia gravis, scleroderma. Do you suffer from painfully cold hands? No. Any dry eyes or mouth? No. 8th differential is neurological disorder. Upper motor neuron lesions. Have you noticed any weakness anywhere? No. That's enough. Because it's a long station, you don't need to ask about every single question to differentiate. Past medical and surgical history. Did you experience similar symptoms in your past? No. Mr. Joe, were you diagnosed with any medical condition? Yes, I have GORD. Do you take any regular medication? Yes, I take omeprazole. Do you have any allergies? I don't have allergies. Have you had any history of surgery? No. Family history. Does anyone in your family have the same problem? No one I'm aware of. Social history. As we said before, social history. Ask if your patient is okay with personal question. Do you mind if I ask you personal question, Mr. Joe? That's fine, doctor. What's your occupation? I'm retired primary school teacher. Who is at home with you? My wife and our youngest son. Mr. Joe, do you smoke? Yes. How many packs per day? Around 2 for 20 years, doctor. If he didn't mention 20 years, we'll ask him. Do you drink alcohol? Yes. How many units per week? Around 1. So just 10 ml, maybe just 1 shot. Do you have any difficulty with the stairs? No, it's fine. Then you're going to ask about eyes, as we showed in the previous lessons, and then systemic review if you have time. Discussion. You will have 3 minutes to discuss with your examiner. Present your patient. I took a clinical history from this gentleman, Mr. Joe, a 65-year-old male complaining of gradual dysphagia that started 6 months ago. Started with solid food only, but now even liquid are difficult to swallow. He lost weight and his appetite is constantly declining. He has a gout for a while he takes omeprazole. No family history of similar problem. He smokes 2 packs of cigarettes per day and drinks around 1 unit of alcohol per week. What are your differential diagnoses? CO esophagus, which your main diagnosis, esophagitis, pharyngeal pouch, echalasia, and autoimmune disease, including myasthenia gravis and scleroderma. How will you investigate your patient? I will do full clinical examination, including lymph node examination. As we said, always mention clinical examination. Then I will request blood investigation, including full blood count, urine electrolyte, liver function test, chest X-ray, esophageal manometry to exclude echalasia, barium swallow, and endoscopy and biopsy. Esophageal abdominal ultrasound, also for staging of carcinoma, is your gold standard. Video fluoroscopy, assessing for aspiration, staging CT, depending on what previous investigation revealed. What is the best investigation of what you mentioned? Endoscopy and biopsy. How are you going to treat your patient? I will discuss my patient in the MDT meeting. According to the investigation, I will determine is my patient operable or no. If operable, esophagectomy plus chemotherapy. If not operable, palliation using self-expanding metallic stent, palliative chemotherapy and radiotherapy, and feeding genostomy. Here at the end, in the school, you will find the differential diagnosis and how to ask about each one. Next one, obstructive jaundice. Scenario, obstructive jaundice due to cancer of head of pancreas. 6 minutes to take history from your patient. Introduce yourself and take permission. You'll have Mark for this one. Hello, my name is Dr. Mark. May I confirm your name and age, please? Hello, I'm Robert. I'm 68 years old. It's a pleasure to meet you, Mr. Robert. I will be your doctor today. Is that okay? So you're taking a permission here. How can I help you today? I've noticed my skin and eye turning yellow, doctor. And my urine being dark. It's been like this for a few weeks now. Analyze the main complaint. I'm so sorry to hear that, Mr. Robert. So you're being sympathetic with your patient. When exactly did you first notice these symptoms? About 3 weeks ago. Does these symptoms start suddenly or gradually? Gradually, but it's getting worse recently. Differential diagnosis, CA head of pancreas. Did you notice any yellowish discoloration of your eyes? Yes, doctor, my eyes are becoming yellow. Did you notice your stool are lighter in color or even chalky? Yes, they are much lighter than usual. Mr. Robert, have you experienced any itching? Yes, I have, especially at night. How about your appetite? Yes, I've lost my appetite and I unintentionally lost weight recently. I'm really sorry to hear that. How many kilos? So be sympathetic with your patient. I don't know the exact number, but my clothes are getting loose. Second differential is choledocholitis, gallstones. Have you had any episode of severe abdominal pain, possibly radiating to your back? I've had abdominal discomfort, but nothing I would describe as severe or radiating pain. Does this pain relate to fatty meals? No, doctor. Third differential hepatitis. Mr. Robert, have you been in contact with someone who has yellowish discoloration of the eyes? No, I don't think so. Do you have fever? No, doctor. Fourth differential, liver cirrhosis. Are you diagnosed with any liver problem? No, doctor. Any history of vomiting blood? No. Why are you asking about vomiting blood? Because if he had liver cirrhosis, usually he will have portal hypertension, which may lead to esophageal varices. Past medical and surgical history. Mr. Robert, have you had similar symptoms in the past? No. This is the first time. Do you have any other medical condition we should be aware of? I have hypertension and I take amlodipine 5 mg once a day. Have you undergone any surgeries in the past? No surgeries. Family history. Does your family have a history of pancreatic issue or any other serious health condition? Yes, my father has pancreatic cancer. I'm really sorry to hear that. When your patients tell you bad event or bad news, be sympathetic and change your tone. I'm really sorry. Don't say I'm sorry. Drug history. Are you currently taking any medication? Just medication for my blood pressure, doctor. Do you have allergies? No allergies. Social history. As we said, we will take another consent here. Do you mind personal questions? No, that's fine. Mr. Robert, do you smoke? I did quit smoking 10 years ago. For how long did you smoke and how many cigarettes a day? I used to smoke 15 cigarettes a day for 30 years. Do you consume alcohol? Just occasionally, doctor. Around 5 units a week. Who do you live with? I live with my wife. Then you're going to ask about idea, consent, acceptation as we showed before if you have time, and the systemic review as we showed before. 3 minutes to discuss with your examiner. Discussion. Present your patient. I took a clinical history from Mr. Robert, a 68-year-old male, presenting with jaundice characterized by the yellowing of the skin and eyes, and dark urine over the past 3 weeks. He reports significant pruritus, loss of appetite, and unintentional weight loss. There is no relation of abdominal discomfort to fatty meal, nor any severe pain suggestive of gallstone. As we said, you may speak in medical terms because you are speaking to a surgeon or a doctor. He denies any fever or recent contact with individuals with similar symptoms, with no prior history of liver disease or significant alcohol consumption. Mr. Robert's family history includes pancreatic cancer, which is very significant, in his father. His medical history is notable for hypertension, and he has smoking history of 30 years, although he quit 10 years ago. What's your differential diagnosis? Obstructive jaundice due to CA head of pancreas, gallstones, hepatitis, and liver cirrhosis. How will you investigate your patient? After full clinical examination, I will perform, and then mention what you're going to perform after full clinical examination. Always mention this one. After full clinical examination, I will perform blood tests including liver function test, CA19-9, tumor marker, complete blood count, and viral hepatitis serologies. Imaging, abdominal ultrasound to assess the liver, gallbladder, and pancreas. Depending on the finding, a CT scan or MRI may be necessary for detailed visualization. Depending on the finding, a CT scan or MRI may be necessary for detailed visualization. ERCP, endoscopic retrograde cholangiopancreatography, or MRCP, magnetic resonance cholangiopancreatography, to visualize the bile and pancreas duct if a blockage is suspected. And I included the picture here for ERCP. The concept, you will go from the esophagus with a probe down there till the duodenum, and then you're going to go retrograde as shown in the picture here. Biopsy. If imaging suggests pancreatic mass, a biopsy may be needed for definitive diagnosis. How will you treat your patient? I will discuss my patient in the MDT meeting as I said. Then treatment will depend on the specific diagnosis. For cancer of head of pancreas, surgical resection if operable, combined with chemotherapy or radiation therapy, depending on the stage and resectability. If not operable, management typically involves palliative care to relieve symptoms and improve quality of life. For gallstones, ERCP to remove bile duct stones. For hepatitis A, supportive care as it often resolves on its own. For liver cirrhosis, management focuses on treating symptoms and complications, possibly including diuretics for liver management and lactulose for hepatic encephalopathy. Thank you, doctor. You can proceed to the next station. And at the end, we created this table to help you. You have your differential diagnosis and how to ask about each one. This will conclude our history stations. The typical one. We finished the typical history station. Next, we will have the atypical history station.